All right. Yeah, we're live. Terrific. Thank you. This is Senate Health and Welfare. It's April that have been referred to our committee and come over from the House. So this morning we're going back to H270 and we're going to hear from the sponsor, reporter of the bill. Why don't you come on up?
Thank you.
Representative Lueders. Yeah.
Thank you.
Thanks for being here.
Yeah, thank you for inviting me.
All right. I think you know everybody around the table.
I think I do.
All right.
Yes, and Ann Cummings, Senator Ann Cummings. I'm not sure we've been formally acquainted, but it's good to see you. I just love you. And I love it when people do that. That shows real focus.
It's me from joking.
Oh, and yes, every other senator, I think I know. Thank you.
Terrific.
All of you. So you're part of my. I'm newly appointed, and so you're part of my education of how things work, crossover and bills you've spent time on already in the House Committee, House Health Committee, and seeing them land here. So it's really good. Interesting to see that process, and it's nice to see the familiar bills here. So it's really big.
Yeah, good. No, and that's exactly what we're doing. We're trying to familiarize ourselves with what you sent to us.
Yes.
We make no promises on
Yes.
what happens to the bill after we
Yes.
hear about it, but
Yes.
what we look for from you is kind of the overview and what's the intent of the bill and what problem does it solve.
Well, thank you very much. This was the first bill I reported out. And it's a bill relating to the confidentiality for peer support folks that are first responders, And so they came to us. It was the Committee on the Initiative of the Vermont Service Provider Wellness Commission, and they said, this is a bill we need to help our folks that are helping you. We show up when things are at their worst and very desperate, and then we have, consequences or debriefing that we need to handle. So they rush in when there's dangerous situations, and then they have to deal with the full impact of whatever they come across. So what this would do is it would provide the prompt, sort of no barrier support of a trained peer, and do so, most importantly, with protections of confidentiality. That's the piece that's been missing. That's what this bill really provides. And the question is, why is this so important for emergency service providers? Well, it has to do with their culture. They are stoic, they have a fear of stigma, and they ask for help, and should they be doing that because they're no helpers? And they also have the fear that maybe their communications would be shared with a superior. Now, we did hear from folks in the superior position, and they are supportive of this, but maybe not everyone would be. So we heard that it really helps for a person in the situation to speak with someone who really understands what they've experienced, to do so in a confidential setting, and that this would be of great help to them. We also learned that first responders take their own lives as a result of the work toll. The toll the work takes, then lose their lives in the line of duty. So there are several ways this peer support might be seen. It could be a critical incident debriefing. It might be an individual responding to a particular traumatizing event. And there's also an issue of cumulative and chronic stress that over time working in this sector imprints on us. So for all these reasons, they asked us to have this bill to help them. So I guess that's the gist of the problem it was trying to solve, where the request came from. We heard from first responders, Burlington Fire Department, state police, secure peer support team, all sorts of folks are actually, they said, just wouldn't help us quite a bit. We ended up with some new definitions, the confidentiality protections, but then in some areas where confidentiality wouldn't apply. So if there was harm to the child, harm to yourself, there's certain areas where the protections would fall away because the issues are too important to be unaddressed. Subject to HIPAA, It's protected like from the public records requests. Otherwise, won't do it. So that's the gist of the.
That's helpful. That's good, you know, and, what was the vote out of committee?
And I meant to say that right at the top. It was 11-0-0.
Oh, wow.
And we did work with it. It didn't, it came to us in one form. We improved it. We heard from folks and we got it to a point that was, as you can see, very well supported by everyone. And we put it out on the floor and this indeed, voice out, voted on the floor. And
Okay, thank you.
pretty straightforward, but also can be tremendously helpful to see folks.
Absolutely. So we've been working on this issue for a while, so it's helpful to see improvements going forward.
Yeah.
Great, thank you.
Yeah.
Okay, well, we'll probably take some time with it.
Okay.
And
Thank you for taking
no
it up.
promises, you know,
Yeah.
we'll
Well,
make it better, whatever, right?
other than the fact that it's already perfect. No, thank you for your work on it and it's really, I'll be tracking other bills in here because I'm familiar with them.
Terrific, thank you.
Thank you.
So it'll be fun. Thank you very much.
Oh, good. So we're actually 2 minutes ahead. Representative McGuire is here 2 minutes ahead, so that's great. We've got a couple other bills. Oh, and John, are both of you reporting on 293?
No, just I am.
Just,
Okay.
okay, so that's,
All right. I thought I was.
oh, are you, who's the reporter?
I was the.
Oh, okay, so then.
There you go.
Yeah. Sorry to kick you out.
Well, it's completely my fault because I totally forgot that I reported it. My first year, I didn't recognize the number when it came, so.
All right, we'll be good. So,
Oh, that, yeah, okay.
so we'll get Rev McGuire back in for some,
Okay.
you're a sponsor. Do you want to stay or anyone? I don't, it's up to you guys.
That'd be like to do.
I'll do it.
Okay. All right.
You take a break.
Appreciate that.
Okay, well, it's good to have backup.
All right, that's from. Okay.
So we're looking at page 293
Yes.
and the report of the village here is it Estes or Easties?
Eastus.
Easties, yes, it is.
Yes.
Yeah.
Just the first four letters are like a direction.
Yeah. All right.
East. Yeah.
So
Yes,
please, introduce yourself and then we like kind of what problems you're solving and what's generally in the bill and see.
guide me along, please. Thanks. My name is Zon Eastus. I serve in Wyndham 1. I'm from Guilford and I also represent Vernon as well. H293 is a proposal that came from the Department of Health last year. And it's very small issues. One was it had four sections to build it. One of the issues was just that the way reports were coming or the timing of reports. The department has asked that with a number of specific reports that they move from reporting every year to every 3 years in order to give them longer timelines for collecting data. So that was one issue. The second issue, the second and third issue sort of worked together. There was a request from the Department of Health to be able to actually share certain confidential information, as is, I guess, practice among other institutions around two issues: specific cancer registries and ALS registries, and be able to share that research and also be able to share databases, certain databases, as other institutions are doing surveillance. The House passed that bill. We talked it through. Everything seemed in order. We talked it through, and then our committee passed it 11-0-0, and as I recall, it was a voice vote, and so it passed.
Terrific.
So.
Question. So it's really alignment of reporting requirements.
Yeah, that's your was, and a slight expansion of certain confidential registries.
Yeah.
But I guess there's a practice out there that that they're just working. So,
Just a quick question on the sharing of data.
yes.
Are they sharing the technical information or actual people's names? So no names
No,
are
no.
shared. That's
Maybe it's called a registry, but as I understand it, maybe you can help me here, but as I understand it, it's instances of situations. but
not the case, not a person.
Right. Yeah.
Got it. Thank you.
Representative McGuire, did you want to add any comments?
Just in regards quickly to the
Yeah.
question, this bill also helps update the standards that are outlined within HIPAA to make sure all of that stuff stays in compliance. And it also, instead of the department having to report back or do a report every year, it's been on out to where the report is submitted every third year.
Thank you. Okay.
All right.
Questions? Anything else? We're good. Thank you very much for
All right.
coming in, both of you. Appreciate
Thank
it.
you. Good seeing everyone.
All right. Katie, here we are.
Here we are.
Good morning. Good morning. So, so what I'm hoping is that this is the last really cold day that we have. I don't have a winter jacket.
Tomorrow's supposed to be.
Yeah, tomorrow's 6. So we'll walk through 293.
Okay,
Then we'll go back to contaminated baby foods.
okay. Katie McGlynn, Office of Legislative Counsel, for the record. Here is H 293. This is a bill that the House worked on last spring. So at the very least, we'll need a new effective date. Because right now it's July 1/25, so that
doesn't
be
work.
updated. Doesn't work. So a few different things. I believe these are all changes that were made at the request of the Department of Health. So you may want to have them in to provide a little bit more context. This first item in section 1, this there was an act that was passed maybe 7 or 8 years ago now that created a health equity advisory committee, and there were different health equity reporting requirements that were also part of that act. So this is amending in subdivision 2, the frequency of reporting by the department on health equity data. As originally passed, it was annually, and now the request is every 3 years, beginning in 2028. By January, the department is to submit a report containing the results of the analysis conducted pursuant to subdivision 1 to the policy committees. What's in subdivision 1? It's that the Department of Health shall systematically analyze such health equity data using the smallest appropriate units of analysis feasible to detect racial and ethnic disparities, as well as disparities along the lines of primary language, sex, disability status, sexual orientation, gender identity, and socioeconomic status. Report the results of this analysis on the department's website periodically, but not biannually. The analysis shall be used to measure over time impact of actions taken to reduce health disparities among. The data informing the department's analysis shall be made available to the public in accordance with state and federal law. So now a specific result coming to the or report, a consolidation of this information coming to the General Assembly would be every 3 years instead of every year if you were to accept this proposal. The next 2 instances of amendment do fairly similar things. The first pertains to the cancer registry that's in statute. The second pertains to the ALS registry that's in statute. I had to go back and check my notes on this because it has been a while since we've worked on
Okay.
this.
This bill was started last year.
Yes.
Right.
Yeah, so it was not fresh in my memory.
Nobody-
I'll go back to this change around written assurance, but both of the sections have language that in the case of researchers, this is about how information in the registry can be shared. There's a sentence, in the case of researchers, the commission shall also obtain written evidence of the approval of their academic committee for the protection of human subjects established in accordance with 45 CFR, part 46. My understanding or my recollection is that this was struck because it only includes institutional review boards and not privacy boards. And that because of a change in federal law in 2017 that excluded public health surveillance from researchers doing public health surveillance can no longer get the IRB, the Institutional Review Board approval. So that's why it was necessary to include privacy boards in this exclusion.
So I've been on institutional review boards, so I understand that. So what's a privacy review board?
I don't understand either.
Okay,
So maybe a distinction between the two.
sure. So in statute, not in statute, in federal regulation that's cited here, we have language that a covered entity, so we're in HIPAA world right now, a covered entity may use or disclose protected health information for research, regardless of the source of the funding of the research provided that the covered entity obtains documentation that an alteration to or waiver in whole or part of the individual authorization for use or disclosure of protected health information has been approved by one of two sources. So this is saying you can use protected health information for research. You can override the need for the requirement that the person themselves has to waive permission to access the protected health information if you have permission from one or two entities. The first is the Institutional Review Board, which I do not have a definition of at my fingertips, but I can grab one. The second is a Privacy Review Board that has members of varying backgrounds and appropriate professional competency as necessary to review the effect of the research protocol on the individual's privacy rights and related interests. Includes at least one member who is not affiliated with a covered entity, not affiliated with any entity conducting or sponsoring the research, and not related to any person who's affiliated with any of these entities, and does not have any member participating in a review of any project in which the member has a conflict of interest. So this is a group of people with some professional competency in this subject area, hopefully per these regulations without a conflict in the research that's being conducted, that can give approval for the use of protected health information as part of an academic research.
So
exercise.
if academic institutional review board would have members of the research community, so it could be the psychology department, the cardio, one other departments, physiology, whatever, looking at the research and then looking at how the data is being used from the human subjects and ensuring that it's done appropriately. And so privacy board might be, and I'm just hypothetical here. I mean, it could be from, suppose it's the Heart Association and they're affiliated with DOH and they're want to do a study on cardiovascular disease and they're using data humans. So they want to access the data, but they have to have a review to make sure that that data doesn't expose subjects. So that kind of ethical consideration. So anything else you can help us with?
Well, so the existing language would just allow institutional review boards
Okay.
to have that waiver authority. And the request is to also allow privacy review boards pursuant to federal statute also have that authority and approving the use of this information in Vermont registries if, for research purposes.
For some reason, I feel squirrely about this, but I don't know why.
Oh, no,
I know.
no, squirrely. Yeah.
Because the individual doesn't know, I don't think, according to what you said, that the data is actually being used.
So here's my suggestion. So how the data gets to the registry is also important. So it could be that the patient has already given permission for it to go to the registry. We don't know that. But we'll get the Department of Health in to answer the specific questions about how the data gets there, and then how it's accessed further. And Katie's gonna. Every time you have a mammogram, they just stop, so I guess permission's on the computer now. They ask you a whole series of questions about your family history, and then they say, "Do you, I have your permission to use it?"
Yeah, but that's not what this is saying.
No, but that would go to some cancer research registry out there.
Okay.
The cancer somewhere. I don't know.
The whole.
There's a whole series of reporting patient information and access. And we have to sort it out before we get too far down the rabbit hole.
We could look at the whole statute. You have an excerpt here. This is a whole section of law that establishes the registry, talks about in what circumstances a provider would submit information to the registry, what specific information is submitted. So we could look at all of that. This change that's happening, I don't think it necessarily addresses your concern specifically, but already there is language in statute that the Commissioner of Health could allow researchers to have access to this data.
I did not know. I talked to.
If an institutional review board approves that, and this just says or privacy board, this is just adding a different type of entity
So you're
that could.
opening it up even more.
Adding
It's
protection.
it's giving a different type of federally recognized
Yep.
entity the ability. My understanding, the Department of Health I'm happy to stand corrected if this is wrong, but from my notes, there was a change in law in 2017 that for whatever reason made it so institutional review boards were not authorizing these studies to the same extent as they were, which is why they want the privacy review boards to be able to. So please hear it from the horse's mouth, because I'm probably not doing it justice.
We'll get DOHM.
Because they mentioned HIPAA. The representative did, they're being HIPAA required.
This isn't a requirement. I mean, this is a HIPAA exemption. So what I read to
Oh,
you.
exemption.
Yeah, so this is HIPAA. There are exemptions in HIPAA where protected health information can be shared for various reasons, like law enforcement purposes, or we always talk about the duty to warn. If a psychologist, psychiatrist, knows that their patient is going to harm somebody, that is an exemption from HIPAA, where the psychiatrist could warn somebody who could stop whatever is going to happen. So this is another type of exemption for research purposes. And this allows an institutional review board or privacy board to review the research that's being proposed and weigh in as to whether protected health information could be used in that research.
So there are questions here. This is good. I don't know if there's more to it than changing dates. It's exactly it. And we'll hear from the Department of Health about why this might be important. Did the change to add privacy board, was that in the underlying bill? That must have been added in the House.
I think that was in the language that they originally proposed.
Okay.
This is a bill that was at the request of the health department, so.
Yes, got it.
I'm assuming this is the ask. I do think, though, that I remember some back and forth about this language, the strike through. The commissioner shall first obtain from such state registries, agencies, or researchers an agreement in writing to keep the identifying information confidential. I think the health department just wanted to strike this language, and human services wanted something written assurance is acceptable to the commissioner. I guess it's not always going to be a contract format, but the Human Services wanted something in writing.
Well, however, we'll have to sort out the difference between a contract and a written insurance when data is being accessed from the Department of Health. Oh, yeah. Okay.
Right.
Anything else in here that you have questions about? Yeah, well, I think the first big change we made is the effective date. All right. You know what I'm thinking? We have 2 more bills and the folks are scheduled. I don't. Callista, is it possible for you to communicate with our 2 reporters and see if they are available earlier than 10 o'clock and 10:45? Because if we could have them in, we can probably go through the bills a little bit faster now and give us a longer time, a longer break.
Okay.
Yeah, so Calista, are you there?
You probably do for food bills.
I think we're gonna just.
Hi, yeah, sorry. I didn't know I was muted.
No, you're good. Can you contact Representative Stone and Representative Rebecca and see if they could come in any soon before 10 o'clock? Both of them?
Yeah, I'll email them right now.
How about, okay, all right, well, email the committee assistant, please, because they aren't gonna check their email necessarily. Do you want me to text them? Sure. All right, in the meantime, I think, Katie, I think we'll go through the bills that we
Okay.
have, and then they can come in and give us. Are you
Okay.
ready to do that?
Yeah, that's fine. 573 is a short bill, but I have some background information, so that might take a tiny bit longer.
Okay,
15
well, let's
minutes.
do it. I mean, okay, let's start with which one? 536 then. That's a shorter for you.
Okay.
Yeah.
Okay. So 536, an act relating to toxic heavy metals and baby food products. We're creating a new subchapter in the chapter on labeling of foods, drugs, cosmetics, and hazardous substances. This section that is being created has, sorry, I'm about to sneeze. Thanks. No, I'm very dusty in here. Thank you. I think I'm okay. Yeah, see, look up here. Sneeze goes away apparently. So this act prohibits the addition of toxic ingredients in baby food products. It takes a tiered approach where infant formula initially is not included in the definition of baby food product, but it's included at a later date. There are some provisions that require testing by manufacturers of the baby food products to see if there are toxic ingredients in the product. And there's also language that requires like a QR code. I'm trying to think of the right phrase. QR code that consumer on the product itself that the consumers could scan, see the results of testing that's done by the manufacturer. So individuals can make informed purchasing decisions. So definitions. Baby food product means any food manufactured, packaged, and labeled in a jar, pouch, tub, or box, sold specifically for babies and children younger than 2 years of age. And as I said, at the moment, this does not include infant formula. Final baby food product means the finished baby food product and not the constituent ingredients. Infant formula means a commercially available milk-based or soy-based powder, concentrated liquid, or ready-to-feed substitute for human breast milk that is intended for infant consumption. Top of page 2 production aggregate means a quantity of product that is intended to have a uniform composition, character, and quality, and is produced according to a master manufacturing order. Proficient laboratory. It's accredited under the standards of the International Organization for Standardization or the International Electrotechnical Commission. It uses an analytical method as sensitive as the analytical method described in the US FDA's Elemental Analysis Manual for Food and Related Products, and demonstrates proficiency in quantifying each toxic element to at least 6 micrograms of the toxic element to kilogram of food through an independent proficiency test by achieving a Z-score that is less than or equal to plus or minus 2. QR code is the word I couldn't think of earlier. We don't need to go over the definition of what QR code is. Representative sample means a sample that consists of a number of units that are drawn based on rational criteria, including random sampling, and intended to ensure that the sample accurately portrays the material being sampled. As used here, toxic heavy metal means arsenic, cadmium, lead, and mercury. Thank you. URL is the Uniform Resource Locator, and US FDA is the Food and Drug Administration. So I should have said at the offset that other states have proposed and a few have moved forward with this language, or this language is based on language that has been proposed in other states.
Okay.
So that is where this is coming from. So first in B, a person shall not sell, distribute, or offer for sale any baby food product in the state that contains a toxic heavy metal that exceeds the limits established by the FDA. The provisions of this subsection shall not restrict the continued sale of inventory in stock before January 1, 2027. So if shipment comes in December of 2026, that could continue to be sold. In subsection C, the manufacturer of a baby food product that's sold or distributed in the state shall test a representative sample of each production aggregate of the manufacturer's final baby food product for the toxic heavy metals. Testing shall be conducted by a proficient laboratory, which we know what that means because it's in the definition, at least once a month. A manufacturer of a baby food may test the final baby food product before packaging individual units for sale or distribution. Upon request of the Office of the Attorney General, a manufacturer shall provide the results of the test conducted pursuant to this section. So the AG's office can ask for the results of any product that is baby food product that's being sold in the state, and that would be provided. In subsection D, without requiring the provision of a universal product code or proof of purchase, a manufacturer of baby food sold or distributed in the state shall make publicly available on its website for the duration of the product shelf life of a final baby food product, plus 1 additional month for each baby product food sold, manufactured, delivered, held, or offered for sale in the state, the name and level of each toxic heavy metal in the final baby food product if it's determined by the testing, sufficient information, including the product name, universal product code, or lot or batch number to enable consumers to identify the final baby food product, and a link to the US FDA's website that provides the most recent guidance and information about the health effects of toxic heavy metals on children. So this would be on the manufacturer's website information about their testing results. In subdivision 2, a baby food product that is sold online to a consumer in Vermont by either a retailer or directly from the manufacturer shall contain the product's webpage. On the product's webpage, a clearly labeled link to the information page containing the information that we just went over in subdivision 1. So this information would be accessible on the product itself if you're in the store. Also it would be available on the website. Or the distributors. It would either be if it's sold by a retailer or directly from the manufacturer. And subsection E, If the baby food product sold or distributed in the state is tested for a toxic heavy metal, subject to an action level regulatory limit or tolerance established by the US FDA, the manufacturer shall display on the baby food product a label stating in a clear, legible, and conspicuous manner that more information about toxic element testing on the product is available by scanning a QR code and a QR code or other machine readable code that directs the consumers to the manufacturer's website or the baby food product information page, providing the test results for the toxic heavy metal and a URL to the web page on the US FDA's website that includes the most recent guidance and information about the health effects of a toxic heavy metal. If a consumer reasonably believes, based on the information provided on a baby food product, that the product is being sold in the state in violation of this section, the consumer may report that to the Office of the Attorney General. And then we have this language in subsection G that we just looked at yesterday. A violation of this section is deemed a violation of the Consumer Protection Act, and it gives the Attorney General enforcement authority. Okay. Then we amended section 2. We amended the section a second time at a later date. And at this time, you can see we're changing the definition of a baby food product to mean an infant formula. And we're striking through the language that says the baby food product doesn't include infant formula. So now infant formula would be subject to all of the language that we just walked through. There is a new subsection being added with the infant formula that the Attorney General shall suspend the application of this section to infant formula if the AG verifies that there is insufficient infant formula in the state to meet the need. If the Attorney General suspends application, the AG shall post a notice on the office's website containing the specific dates that the suspension is in effect. And then I wasn't clear about the effective dates, and that's because we have a contingent effective date in this bill. So everything that we looked at in section 1 with regard to baby food products and excluding, adding in the infant formula, that takes effect January 1, 2027. Section 2, the adding in of the infant formula provisions, takes effect upon the AG's written confirmation to the Speaker and the Pro Tem, which shall be posted on the General Assembly's website, that either California or 2 other states have enacted legislation with requirements substantially comparable to the requirements of this act regarding all of the following: the prohibition on the sale and distribution of infant formula that contains a toxic heavy metal exceeding US FDA limits, the required testing of infant formula sold or distributed in the state for toxic heavy metals, and the labeling of infant formula and the provision of information about toxic heavy metals in infant formula. So if another 2 states or just California has an infant formula law that does these 3 things in a substantially similar way to Vermont, as confirmed by the AG's office, then this would take effect.
This last section dealt with one of my concerns whenever we've done these kinds of restrictions before. The danger is Vermont is such a small part of the market that we just, fine, you want us to, label it a special.
Do not get baby
Vermont,
Right.
we're not getting
No baby.
baby food or formula. So generally, we tied it like to 2 other New England states and New York. California is a whole different market. It's the other side of the country. I feel better if it were,
And it's
where they're shipping it is closer to.
I think I was not always in the room when they were talking about this. I think what you will hear them say is because California has such a big impact on the market that when California passes a law like this, manufacturers have to make the change you know, for all of their products. And so that was why California was chosen. I would,
Usually we look at New York. So,
well, I'm sure the sponsor.
New York
or the-
usually
Yeah,
that
I mean,
follows what we do.
that's,
So.
it's just, I wanna make sure, because I'm assuming that this is over and above any federal FDA.
Right, that was my
Damn.
goal.
I mean,
Yeah,
to me, you're selling
Right. My
baby
question,
food
yeah.
with toxic materials in it. It's gotta be the degree that's different.
So, yeah, the California market does drive a lot of changes across the whole country. So
Everything.
I'm less worried
This
about
is
that.
found to cause cancer in California.
Yeah, so when we did BPA, for example, we're the first day to do that, James, that. When we did other things, which one? I don't know. where
We
did
did
follow?
efficiency
We didn't really
standards
follow
for
California, a lot of this. They followed-
washing
so-
machines
Yeah,
in Walmart.
well, so the point is, it's a large
And it
market.
was tied to,
Let me ask a question, Senator. Katie, was there testimony about EU reach? Does the European Union have this type of,
Oh, there may have been, but
okay, so under the.
this was happening during.
This
leading
is
up to
happening
crossover. and
Everywhere
I-
during crossover.
I was
Okay, we'll get information.
Popping in
that
and
will
out of lots of
help
rooms,
us.
so.
Yeah, so,
I'm not,
you can't keep it all straight.
I did not hear all the testimony on this still.
okay, we'll sort it out. So we've got testimony. I know that this is a strong interest of some of our environmental groups. And it's also a strong interest on the part of others who are concerned about children and babies. So we'll get folks in on this. We'll hear from Mary Catherine Stone, who is the, I think, reporter of the bill,
No,
sponsor of the bill.
sponsored the bill. Who reported the bill? Representative Nels, maybe?
No. Yes,
I think I remember. Oh, you're confirming. Good. Thank you. Okay.
okay. So, well, we'll have, Mary Catherine Stone is signed up to come in, so when she comes in today, we'll listen to her.
Okay.
And then we have a lot of questions. There's no, I understand Senator Cummings' question. California's way across the country. What effect will it have on us? And I do have a couple questions. Oh, EU breach was one, and then the other one is more closer to home, and how do we deal with local manufacturers? Obviously, they'll have to follow this requirement. I mean, I don't, we did have a local baby formula manufacturer in Franklin County.
Yes,
I don't know if it's still there.
I think,
Not there.
I think they closed.
Yeah, they did. Okay. So those kinds of questions.
I mean, I still want to understand the difference between what this bill was trying to do and what is already covered by federal regulations, because we're referencing the U.S. Food and Drug Administration. So are we, if that's what we're using as standards, then what is it that this bill is doing that I've already done? So,
Their standards might not be adequately high.
yeah, well, I'm just saying that's the standard for reference. So it's not setting any difference.
So we'll see what the story is. And Katie, maybe you could help us. What at the sponsor, and we'll ask others to testify, but in terms of what FDA requires and what this bill, state is always allowed to take another step.
Right, and they are.
Sure.
Yeah,
And
I take
that's what this is.
Well, I don't know how much.
So we want to know what that next step is.
Yeah, what problem are we trying to solve?
Well, we don't want to kill babies.
There's the
Well,
big
no, but I mean, are we saying that the federal regulations are not,
Stringent.
that the federal regulations are allowing people to, for,
Put cadmium out on the market.
yeah,
Heavy metals.
it may be for,
And they are.
Right.
That's the point. I think that's what's implicit or
right, well, I think that's just,
Hey, I understand.
No.
It goes,
Nothing.
so.
It's referencing
what I'm
the
trying to figure out.
good question.
This is requiring not annual,
Testing.
monthly testing, and it is requiring that the information be readily available to consumers. So
good for local.
You can make a
People.
choice about how much cadmium you want exposure into.
Right.
Okay.
I remember when girls were small, but big, little baby chairs. And
Yeah.
you're gonna put all the information on, but the QR code,
That's
yeah,
true,
it's
those
very
labels are tiny.
tiny.
Yeah.
tiny.
You can't read them. Yeah, don't give it to the grandmother to read. All right, so this is fun. I mean, Katie keeps opening up little cans of worms.
Sorry about that.
This is good. We got lots of questions. We'll get folks in to testify. Well, Calista will help us. We have folks who testified in the House, and we'll bring in them and others who are sorted out, get our questions answered. It's great. Okay, so let's go through. We're on a roll, so we may as well continue.
Okay.
And when Mary Catherine Stone comes in and Representative Rebecca will come in, we'll hear their testimony and we'll see how that sorts out. So let's go to 573.
Okay. I was hoping to provide a little bit of background information about how somebody would get to in a hospital involuntarily before we look at the language in 573. Is that an okay use of your time? Would you like to hear that before we jump into the language?
Uh-huh.
I was thinking it might
Good.
give more context for the bill. Okay. So I have this slide that shows how somebody could find themselves at a hospital for psychiatric care. This forensic exam, those are people coming in through the criminal door. I know you've already heard a lot about that this year. Somebody could come in voluntarily. And then we have these two boxes up above. There is a warrant and certificate for an emergency exam, or an application and certificate for an emergency exam. So we'll look at each of those in turn, but basically, the application is what it sounds like. Somebody is observing that a person could possibly be meeting the statutory definition of a person in need of treatment. And so they are applying to have this person examined to see if they do need that hospital level of involuntary treatment. And then that would be paired with a certificate for an emergency exam. And those two things together would be what's needed to transport the person involuntarily to the hospital for an emergency exam. In the event that an application can't be completed in a timely manner, for whatever reason, there could be a warrant that a judge would sign off on in the place of the application. And that warrant and the certificate for the emergency exam would be what's needed to transport the person into the hospital involuntarily. So these are existing provisions that provide the groundwork for how to involuntarily transport a person. Okay. So that first one we talked about the application. So the authority to transport and admit a person to a hospital for an emergency exam requires the application by an interested party and a certificate by a physician who is not the applicant. So a physician also has to weigh in. The application, yep.
What is an interesting party?
It's open-ended. It could be the person's provider that they're seeing. It could be a family member. It could be a law enforcement officer or social worker that's working with a person. Mm-hmm.
Yeah, that's someone did not let anybody go.
So the application and certificate must state the facts and circumstances constituting the need for the emergency exam. And the emergency exam is sort of the step before there is a court process to hold the person in a hospital involuntarily. So this is just to get the person to the hospital for the emergency exam. And then the person is held for admission at a hospital for the emergency exam to determine if the person meets the statutory definition of a person in need of treatment, which means that they're a danger to themselves or others. It's a little more nuanced than that, but generally speaking. Then we have this alternative, which is the warrant. So personal observation by a law enforcement officer or mental health professional that the person's conduct constitutes reasonable grounds to believe that the person is in need of treatment and the person presents immediate risk of serious injury or self to others if not restrained. The application for a warrant requires that there are emergency circumstances and that the physician certificate would be unavailable without serious and unreasonable delay. So this court warrant, this warrant that's issued by a judge, takes the place of a physician having to weigh in, as the physician has to do in the previous step. So this gets the person to the hospital for an emergency exam with a court order rather than a physician.
Even if they say, no, I do not want to come.
Yes, this is an involuntary process. Yeah.
Just an observation. It'd be so interesting to know or learn how much schooling or, you know, training law enforcement get in terms of how like mental illness presents. Because I just have absolutely no idea what kind of training they get.
There's that team too.
There's the team too.
Yeah.
And they have been in, to talk with us about the training they give at the police academy in Pittsburgh. And then we also have all the EMT training that goes on. So there's we could get team 2 in. That might be a good thing to do. We haven't had them in a while. Just don't want to talk about the budget. So, okay. Yeah, good question.
So this is just to give you sort of background information, because I think if you look at the language, you'll be wondering what are we trying to do? So this is just sort of a chart to show you the steps that are taken before somebody is involuntarily committed. So what we're going to be talking about in the bill today is, can you see my mouse? Is this area right here, this bullet. So the authority to hold a person for admission at a hospital for an emergency exam can either be done with the application and certificate or the warrant and the certificate. Assuming the person gets to the hospital for the emergency exam is conducted by a psychiatrist as soon as practicable, but no later than 24 hours after the initial certification. The psychiatrist does not certify that the person is in need of treatment, so the person doesn't meet the statutory standard. They're discharged. If the psychiatrist does certify that the person is a person in need of treatment, the person is held for 72 hours. What happens in that 72 hours? That brings us here. In that 72-hour period after the emergency exam, the hospitalization is terminated unless the person either voluntarily accepts to be admitted to a psychiatric unit, or the person doesn't voluntarily, doesn't want voluntary admission. Then there is a court process that's initiated. That's an application for voluntary treatment that's filed with the court, and the court weighs in on whether the person can be held involuntarily for mental health treatment. We're not dealing with that in this bill. We're not dealing with the emergency exam. We're just dealing with this piece. So it's important to note that the emergency exam is conducted by a psychiatrist, but when we're doing, let me go back to this slide. When we're doing the application and certificate for an emergency exam, that certificate is done by a physician, not necessarily a psychiatrist. So, yeah, I feel like you have a question.
So any physician can do it.
Yes. That's the current practice. And now I'm gonna switch to the bill.
It's an ED physician.
Any
doc.
physician.
Any physician. That's good.
For, I'll show you the language. Okay.
What's driving this, Madam Chair, I take it, is we're having issues with individuals.
Yes.
Yes, and we'll have the reporter give the overview, and then as we get testimony, it'll be greater.
Thank you. Yes.
So
Ongoing.
I'm gonna do this out of order. So here's our statute on application and certificate for emergency exam. Gonna scroll down to the bottom. Where we have a definition of a healthcare professional, it's replacing the phrase certifying physician with healthcare professional. And a healthcare professional means a physician, an APRN, or a physician assistant. So that's meaning that, well, first, an APRN can already do what a physician can do under statute, so that is not a change. So an APRN is already conducting these examinations. What this would do would be to add a physician assistant, being able to certify on that application to transport the person for an emergency exam. So a lot of words on the page, but that is really the thrust of what all the language does.
So it expands
It expands who can do a certification to transport. So
There's three, there's an APRN, physician assistant, there's a one.
physicians.
physicians.
So the statute already says physician. We already have statutory language that says APRNs and can do these tasks that a physician can do. So APRNs by default can already do it. So the practical effect is PAs are being added. I see that you have sponsors. Do you want me to pause here before we actually walk through the language?
Let's do that, and
Okay.
we'll hear from Representative Stone, on the bill. We actually started looking at the bill already, because we have more time than we expected this morning. So it'll be great to have you come up, and we'll put our heads back into, Davey.
Long time no see.
I think you have it.
Yeah. Yeah. Anxiety to crisis.
And the deal to switch.
Yeah, yeah.
You want to,
Yeah.
can you tell that my child is before time? This is for police drive, struggling.
Fill the.
Okay.
So we went through the bill, but it would be helpful to hear from you, sort of the problem that's being solved, the broader context of what's important here.
Yep.
And then go from there.
Okay, I am Representative Mary Catherine Stone from Vermont. For the record, thank you for having me in here to speak about H536. I want to start by sharing the why behind this bill, why it's so deeply personal to me, and why I felt compelled to introduce it here in Vermont. I first heard about this issue in this bill from my friend and colleague, Delegate Michelle Maldonado of Virginia. She was speaking about a rare bipartisan win in her state in the Virginia legislature during a time of increasing polarization, and that alone caught my attention. I wanted to know what kind of bill could unite lawmakers across party lines in today's political climate. And when I learned it was legislation addressing toxic heavy metals in baby food, I started digging deeper, and what I found was really alarming. Around that same time, I was pregnant and thinking really carefully about every choice I made affecting my child's health. And I was shocked to learn that even now, in the current year, 2026, toxic heavy metals like lead, arsenic, cadmium, and mercury are still found in foods marketed for babies and toddlers. As parents, we assume baby food is one of the most highly scrutinized products on the market, but the reality is that testing and disclosure are not consistently required, and parents often have no way of knowing what is in the products they buy. My concern is not only personal, it's also professional. So for those of you who don't know, I'm a licensed and registered occupational therapist with significant experience working with children. I have worked in pediatric settings, including a NICU step-down unit, where I helped infants develop feeding skills. I have spent years supporting child development and partnering with families on nutrition and growth. And yet, even with that background, I did not know this was an issue until I started researching it myself. And that realization was really powerful. If someone with my training and experience was unaware, how can we expect the average Vermont consumer to know? That told me immediately that transparency itself is a form of consumer protection, and it's not theoretical. In my digging, I found that in Maryland, they passed a bill similar to the one that is before you today, and it's called Rudy's Law. It was inspired by a child who suffered lead poisoning due to contaminated food pouches. That story underscores this issue has real world consequences for real families. That exposure, even at low levels, can affect neurological development, learning, and lifelong health outcomes. Unfortunately, that child I mentioned passed away due to that exposure. Other states are recognizing this. California, Maryland, Virginia, and Illinois have all passed similar laws requiring testing and transparency for baby foods. And these efforts have been bipartisan and grounded in public health, not politics, which is one of the main reasons I love this bill. They show that this is a workable policy and states do not have to wait for federal action to protect their residents. What this bill does is straightforward. It sets expectations for testing, disclosure, and transparency so parents can make informed decisions. It aligns with federal guidance while closing gaps that currently leave families in the dark. It does not ban foods. It does not vilify manufacturers. It simply says that when products are made for our youngest and most vulnerable Vermonters, we should meet a higher standard of openness and accountability. I've already heard from legislators in other states, as well as our own advocates, medical professionals, environmental groups, families who are ready to testify. The Vermont Medical Society and others are interested in this conversation because they see the public health value. The breadth of support and the diversity of voices really reinforces what I believe really strongly, that this isn't a party issue. It's not even a political issue. It is a public health issue. And at the end of the day, parents shouldn't have to be chemists or policy experts to feel confident feeding their babies. The least we can do is ensure they have access to clear information and that we are minimizing avoidable risks wherever possible. Our children here in Vermont cannot advocate for themselves, so it is our responsibility to do so. And that is why I brought the bill forward, and that is why I asked for your support. And I can go through changes from how it was introduced to how it was passed, but that's the bulk of the why.
This is terrific. It's perfect. Thank you. You answered a lot of questions that were asked before you came in about states that have already done this or would be doing it. So this is really helpful. What was the vote out of your committee?
The vote out of the committee was unanimous.
Unanimous, and then
And on the floor, one voice of opposition, and that was it.
what was the pushback?
The one person on the floor received an email from a manufacturer in Franklin County and they were worried, but that manufacturer's closing next year and moving out of state.
That's the one I was asking about. Yeah, so
So,
you're gonna close before it would affect.
yeah,
Yeah,
it brought together some like pretty cool allies, I will say, in the house.
good.
Now, so it was another good like bipartisan experience.
We like that.
Yeah,
Yeah, thank you for your work on this. It's really.
yeah, yeah.
Next one. Could
Go ahead.
you go back through the list of states that have enacted
Mhm.
similar legislation?
California, Maryland, Virginia, Illinois.
All right across the country.
Yeah,
Yeah.
Representative, are you seeing manufacturers making the changes? And if they are making the changes, are they gonna do it nationally? Once
Yeah.
they start, I gotta imagine,
Once they start, they have to.
that's what I'm guessing, right?
yeah, once they start,
So they have started
right.
changing it.
Right.
Okay.
And like the idea of like, oh my gosh, what if we enacted this and there'd be a shortage? None of these states have had shortages because the manufacturers made the switch and then they're like not just gonna carve out and put QR codes for Virginia. They do it for every state. So
So are you starting to see it in the state? Are you starting to see the QR codes on the
Yes.
thing?
Representative Richard Nelson did a little field trip on his own and he was sending me pictures from his local, up in Durham.
Yeah.
That he was finding QR codes
Well,
on the
that's-
back of baby food.
Fantastic.
So.
It's good.
Yeah, I can't read it.
The other question, did you hear anything about what the European Union is doing, EU reach or anything related to their testing of baby foods?
I think they talked about it maybe briefly, but I don't think they've like formally brought
Okay.
anyone in.
But
I
that's
know
a
that it's
huge
more
market.
scrutinized
Yeah.
in other places than it is here, which is wild to think.
Yeah.
But,
I doubt that it's.
They probably have.
right,
very
exactly,
good
with their
standards
makeup and
there.
everything, every time I, yeah.
Any other questions for Representative Stone? Go ahead.
Do you know, are there other states that are looking at enacting similar legislation?
Yes, and there are other states who are also looking at infant formula, and that's something that I also wanted to talk to. It's in the House version. They put an amendment on there.
Yeah.
Yeah.
Yeah,
We saw it. Yeah, good. It sends it out a little bit of time. but-
yeah. Yeah, it has some safeguards in there, but I would encourage to just for y'all to dig into that a little bit more to consider whether Vermont could take that step forward responsibly rather than waiting for others to go first. Like I said, the argument that manufacturers will pull away from Vermont after talking with other states who have put forward like the baby food, they did it. I mean, the concern is real, but manufacturers have stepped up and changed their practice, and this is the conversation that's happening in other states. And yeah,
Good.
I just want y'all to think about that.
Thank you.
Yeah,
We are thinking about it.
good.
We're gonna look at it.
And I would have brought my little baby with me. That was my plan, but
Oh.
the 4 month sleep regression is real. Not my sleep last night. Which you be.
Oh, didn't sleep last night. That's not good. Oh.
Thank
Oh,
you.
Senator Rebecca is here right on time. Hey.
We planned that.
So committee, I haven't heard anything about not taking up any of the bills so far that we've been looking at, so we'll just keep going right along. We do have a couple of, we have one very large bill coming to us that we're gonna look at next week.
There's just one that I need to get into.
Oh, yeah, we have information. We can't make decisions until we hear the data. You can't make a decision up front. You never know what you don't know. Yes. So we're gonna listen to Representative Rebecca on H 573. And just so you know, Katie did go through it with us a little bit. We haven't gone lockstep through it yet. We just got her introduction to what might be affected in here. But what would be helpful for us is to hear your overview of what the problem is and how the bill helps solve it.
So you all know what an emergency evaluation is.
Yeah, okay.
And you all know who we're talking about when we're talking about needing an emergency evaluation. These are folks who are in an acute mental health crisis, so they're at risk of harm to themselves or others. Often this is happening in an emergency room. Unfortunately, that's sort of become the front door to inpatient mental health care for folks that are in acute crisis.
We're trying to change the pathway.
Yes.
Yeah, so maybe just talk a little bit about.
So, under Vermont law, a first certification in this process of emergency evaluation. We're talking about involuntary commitment, just to be clear. The first certification authorizes the person to be held for an emergency examination. And within 24 hours, the psychiatrist has to independently examine and certify that person, or the individual could be discharged. If the psychiatrist issues the second certification, the person can be held for up to 72. Okay. And then they have to receive notice of written notice of rights, including access to Vermont legal aid, mental health care ombudsman. So those safeguards are, none of that's changed by this bill. And I guess the overview is that EDs, again, are the front door related to psychiatric crisis care. And this is not only destabilizing for patients, it's destabilizing for everyone who is working there, and is not trained in how to support these folks who are in crisis. And it limits access to other folks who are there with broken arms, legs, etc.
So what we want to do is we want to sort of open up what is in some hospitals a bottleneck, because right now APRNs and physicians are the only two hospital staff who can sign off on the first certification.
Well, okay, I thought it's just positions.
Physicians and APRN.
APRS.
This bill adds physician assistants
Right.
who are in practice, most often they're actually the ones doing it. And frequently we heard they do the first certification and then they wait for a physician or APRN to come sign off on it. So this is really just reflecting what's happening in practice, and it's aligning that. Yeah. Doesn't eliminate the 24-hour psychiatrist second certification. So we did have both rightfully concerned that this is making it easier to involuntarily commit someone. So this doesn't do that at all. What it does is, again, it just makes sure that it gets someone to a psychiatrist faster, and it gets them out of the emergency room where they're not getting the care that they need.
So generally what the bill is doing is it's shortening the wait list. It's removing people from the ED who are better placed elsewhere. And it makes sure that they're cared for in a more timely fashion. So that's kind of the way I look at exactly here and say, okay, I can see where this would look in Sheridan County. We've closed the psychiatric unit up here because I think we lost all our psychiatrists.
That's gonna be my question.
I'm wondering if up in your area, I mean, have we got psychiatrists available? We'll get this at testimony, Senator. Those are the kinds of. I mean, I'm just wondering if you've heard any testimony. Yeah.
Yeah, this is at the front end of the process. So
Yeah.
And what's the accessibility of it? I mean, if you bring that individual in the middle of the night, but it's 24 hours, 72 hours. But getting a psychiatrist there.
they do the second exam.
Yep.
So
But you gotta let them go after 24. And if you can't get the psychiatrist there.
we didn't hear any.
So we'll
Concerns
take
about that?
testimony, Senator.
Yeah.
So right now, let's just get the overview of what is in here. This is good.
And this was very welcomed by hospital workers.
I've already heard, I've heard. We've heard. This is good. No, thank you for introducing it. Did you introduce the bill? Did you report the bill? And what was the vote in committee?
Oh my goodness.
Probably
I
11.
did it last time I came in here. I believe it was.
And then voice vote on the floor. Was it?
Yes, voice vote.
Okay. That's good. No, it seems like a solution to a problem. Useful.
Yes, the other thing, and Kate probably let you know this, is that we did add into statute that anyone who does the first certification has to take a DMH offered training. And I believe that wasn't in statute, but we're putting it there.
Putting it.
And we did a little housekeeping somewhere about it, so we, whatever it takes, and I worked with Representative Donahue on that.
Oh, and we'll hear from Katie going through the bills and the details.
She did, she even said something
did
on
good.
the floor and supported this bill, so I worked very closely with her on this.
Good. Okay, that is the stamp.
Yes.
Senator Drew has a question.
Thank you for being here. What does the DMH training look like? Is that like an online training or?
It's a manual, yeah, I think it's, I know there's at least a manual with it, and I believe they shared it with us, and I can forward it to you, so, but they can talk to you about the training.
Good, thank you. Got it. Thank you. Thank you for being available early, because we've just run through all of our work this morning, and this will give us a.
So efficient.
And thank you for taking up so many mental health pieces. I think you also took up my mental health and AI though. And then,
Good, you may be back in to give us the overview on that one, that would be good too.
I think Wendy did.
Yes, that's right. We're good.
But the school one,
Reporters, okay.
if you haven't seen. that
Yeah,
yet.
no, the mental health has been on our agenda now for a few years and, so we've worked with the judiciary and competency restoration, and we're working on mental health training for local EMTs, and this is all coming together. It's really good.
And some of it's coming upstairs now, so thank you.
It's good. You're getting it. Thank you.
Thank you.
Oh, yeah. So Katie, you wanna check, go through with us? Not a long bill.
No.
Not a lot. in it.
So with that health care professional.
So I'm gonna start back at the top.
Oh.
I skipped ahead just so you sort of, I feel like the punchline is at the end. The PAs are who can now do the certificates. But maybe we'll start at the top. So there's this section, 7110. And as we were in the process of putting this bill together upstairs, there is language in this bill that is contrary to the process I just laid out to you when we were going through the process, the overview. And it's not the practice of anyone in the system. So the proposal is to repeal it because it's not what is currently happening or what folks seem to think makes sense. So this language says that the certificate, a certification of mental illness by a licensed physician required by section 7504 shall be made by a board eligible psychiatrist. And remember when we went through that overview, we said, well, the physician can do the, they call it the first search, and then the psychiatrist does the emergency exam. So this is different than what is happening in practice, hence the proposal to get rid of it. And then it says in the areas of the state where board eligible psychiatrists, et cetera, are not available to complete the admission certifications to the Vermont State Hospital or its successor in interest, the commissioner may designate other licensed physicians as appropriate to complete the certification. So I think that's how we got to the point where physicians do it now. But now the practice is that physicians do it. So the proposal was to just repeal this section. Okay, that brings us to section 2, and the first line brings us back to the comment or the question that Senator Benson had earlier, which is who is an interested party who can do this first certification. And you can see here that that language is being struck out and it's being replaced with the term of qualified mental health professional. So upon written application by a qualified mental health professional, so that is the person who could do the certification. That's not a defined term in statute, but it is meaningful in the field as a term that's used with relative frequency. So upon written application by a qualified mental health professional made under pains and penalties of perjury and accompanied by a certificate, instead of by a licensed physician, by a licensed healthcare professional, which we now know physician, APRN, EA as defined below, who is not the applicant, a person shall be held for admission to a hospital for an emergency exam to determine if the person is a person in need of treatment. The application and certificate shall set forth the facts and circumstances that constitute the need for the exam and that show that the person is a person in need of treatment. B, no changes. C, a lot of the changes in the first half of this subsection were sort of, they weren't the point of the bill, but as we started walking through, we found that the language just felt confusing. So we tried to rewrite the sentence in a way that has the same meaning, but hopefully says it in a clearer way. So the new sentence is admission of an individual to a designated hospital for care and treatment under this section shall be overseen by a head of hospital who may designate a person in writing to discharge the authority of this subsection. Prior to that, I had read, for the purposes of admission, an individual to a designated hospital for care and treatment under this section, a head of hospital as provided by subsection A, may include a person designated in writing by the head of the hospital to designate the authority granted by this section. So,
That could be simplified.
yeah, so the goal is to make that clear.
What is a designated hospital? Designated person.
Or designated hospital.
No, designated hospital.
Yeah.
So is every
that was-
hospital designated to receive mental health patients or only a few?
I believe, and we have DMH minutes to correct me, but I believe a designated hospital are hospitals that could receive level 1 patients. Is that right?
So designated hospitals are for involuntary hospitalization overall. So if you're in care custody of the commissioner, and then level 1 is just Rutland and baby speech.
Well, thank you.
So we'll have you come in and give us some thorough testimony on this. Claire. Thank you.
Yeah, I don't know, we're critical care hospitals, I don't know.
Okay, right, we'll have to sort out the distinction.
I'm guessing they're going there now.
They receive involuntary
Yeah.
patients. it
Well, they
sounds
show
like they
up
are
in the
designated.
Right,
emergency,
that's what I mean, so they're
Yeah.
showing up.
but that doesn't mean they're designated
Correct.
to receive them involuntarily,
Correct,
which means they're sitting in for emergency.
correct.
So then we have this sentence that is really the whole point of this bill, that the designated person must be an official hospital administrator. Oh, this is not the whole point of the bill, sorry, we did that up above, but we're being consistent. A designated person must be an official hospital administrator, supervisory personnel, or a licensed physician on duty on the hospital premises other than the certifying healthcare professional versus physician, because now that's broader. As Representative Rebecca said, we have this training requirement added in subsection D. Prior to issuing a certificate pursuant to this section, a healthcare professional shall successfully complete a training developed and administered by the department. And then E, as used in this section, healthcare professional means a physician, APRN, or PA. This takes effect July 1, 2026.
So we need to sort out the distinction between hospital, designated hospital, and among other things, and then hear from folks who are directly involved, but we also want to hear from DMH on this. How that helps.
And what's mean by the head of a hospital? Is that the general manager of the hospital? Because I envision that can mean a couple different things, to be honest with you.
We sort of had the same debate upstairs as we were writing this. Who is meant?
Yeah,
Who is that of the hospital?
Oh, is it the head, is it the chair of the board?
I don't know. I got no
Is it the
idea.
CEO?
Yeah, I
Is
don't
it the
know.
CFO?
And Boss, I think, on the spot, sat down and gave a quick analysis. So you
Okay,
might
we'll
want to
get
hear
Boz
from
and
Boss.
All right, what if the head of the is on vacation?
So that, hence the
Why?
designation.
It can't be reached.
They can designate this
They can
authority in
Right.
writing.
Right.
The authority
Still
to discharge, yeah.
Anything else we need clarity on? So we'll have Boz in, we'll have DMH in, we'll have PMS and the Board of Medical Practice, I guess, no. Did they testify upstairs? Oh, look, well, we'll look and see who testified. We don't need to go too far. Yeah. Any other questions?
You're gonna be busy.
No.
They're all
Short bills with absolutely no problem.
That's just very easy.
We'll work on it.
Famous last words.
I know, for sure.
Nothing is simple.
Especially in
Hey.
healthcare.
Yeah. We're good, I think.
Okay.
Just can you move the little guy?
I'm sorry, I wanna know what your,
Before we go off,
what is your goal?
we can go off live, Callista,